Okay. Um, so what are the etiological factors? Basically, a blunt trauma, accidental trauma, road traffic accidents, a penetrating injury, intubation, we already seen, post radiation. I think more and more head and neck surgeries and surgeons opting for organ preservation and sending patients for radiation. These patients do come with supraglottic edema and stenosis because of radiation. The commonest cause what we see is thermal or chemical burns, and the commonest is organophosphorus poisoning or corrosive poisoning in children and adults. The chronic inflammatory diseases, I mean all the chronic inflammatory diseases are going to affect the supraglottis because of course the epithelial nature, right from tuberculosis, sarcoidosis, scleroma, rhinoscleroma, we have seen few cases, and all other these entities, diphtheria not common these days, but these are going to affect the supraglottis. Amyloidosis, then papillomas, chondromas, these are to be seen in the supraglottis more commonly than anywhere. These are uncommon, but again Wegener's you will be able to see in the supraglottis obstructing the airway. Now I will just going to show you few cases which are common and which come with breathlessness because of the lesions in the supraglottis. A blunt trauma would result in dislocation of the arytenoid cartilage, supraglottic collapse and breathlessness. This is a pre-op stroboscopy. So what you see is collapse of the arytenoid cartilage here. So this is a collapse of the arytenoid cartilage into the airway, and again what you have to do is arytenoidectomy, which is transoral. This is immediate post-op, and the patient would get.
Take a deep breath. Very good. So this is restricted only.
So what I have limited to the arytenoid only and not of much of the vocal cord.
Take a deep breath, man.
So the voice also seems to be quite good for this patient. Now laryngomalacia, we have seen the excellent presentation, so I have removed much of the slides. Two or things I just want to mention. Laryngomalacia is the commonest pediatric airway disorder which is going to come to you. It can be managed very well with whatever methods we have already seen in the morning. The results are very good, and you can almost get rid of tracheostomy in a pediatric age group. And that's why I think again and again flexible laryngoscopy, correct diagnosis and managing these children is very important. I'm just going to show you what clips we are not able to see. So basically a type 1 laryngomalacia is what is defined is a short airy epiglottic folds and a tubular epiglottis. So this is type 1, and what we do the surgery is just cut open with the scissors midpoint incision over the airy epiglottic fold and open up the larynx. So the short airy epiglottic folds, you just release them, and the epiglottis you can do epiglottopexy. But basically the surgery is just incision at the midpoint of the airy epiglottic folds, and beware, I mean just remember there is no major blood vessel at this particular point. So you can just take scissors and cut open, just make a cut and have excellent results. Number 2, type 2 is basically a redundant mucosa which on inspiration blocks the airway. See the same, you can see the slide here. The mucosa over the arytenoids is prolapsing into the into the airway and blocking the supraglottis. So this is type 2. And what is the surgery? Again, you can just cobbleter, laser, or hold the prolapsed mucosa with a forceps, take a scissor and just release this or cut this mucosa. So, I mean, again, a fruitful surgery, and we have already seen this posterior. So this is posterior displacement of the epiglottis, which shuts the laryngeal inlet during inspiration. So what's happening during the inspiration is this epiglottis, because of the immaturity, falls down into the airway and blocks the airway. So, okay, and this is just remember, this is I think 10 days old child, and this is second case I did around 18 years back. Wonderful results. So just to promote this this surgery for laryngomalacia, I am again going on to these slides. And what are the risk factors? Very well explained, but just to explain them, we are doing surgery on the aryepileptic folds, on the arytenoid mucosa, and over the epiglottis. Now when you are doing raw area on almost entire circumference of the larynx, beware to leave in between the normal mucosa. Otherwise, there could be supraglottic stenosis following the surgery. So that's the complication you should be aware of while doing the surgery. Okay. Now we have seen again prolapse of the arytenoid cartilage because of the blunt trauma. This is pre-surgery and this is post-surgery. We have already seen this clip, so I will release this. Now this is the case. I think what here you can see. Okay, so this is the stenosis in between the false vocal cords or the ventricular bands, and what you can do is just you can just do laryngofissure and open up this. But what's the advantage of doing transolar surgery and with the lasers? You can do layered dissection. And what's the advantage of layered dissection is you can avoid trauma to the true vocal folds. Now remember, a patient with supraglottic stenosis usually comes to you with a tracheostomy, and when you are not able to visualize the vocal cords, don't claim or tell to the patient about the phonatory outcome of the surgery. Okay, so a patient of this who has come, this was a bullet injury actually, he has a false vocal cord stenosis here, had come with tracheostomy. So he says, what about the voice after the surgery? So because I am not able to see the vocal cord movement or vocal cord integrity on video laryngoscopy, I would not commit anything. Okay, now if you want to check whether the true vocal cords are free from the false vocal cord stenosis, what you can do, these patients generally come with a tracheostomy. So you can do a retrograde examination. So retrograde endoscopy through a tracheal stoma, either with a flexible laryngoscope or a 70 degrees sinus endoscope, and check the integrity of the vocal cord and vocal cord movement. Okay, so I mean these are the only two things I want to tell. Number one, in supraglottic stenosis you can't see the vocal cords, and number two, if these patients would come with the tracheostomy, so learn to do retrograde examination through the tracheal stoma. Now oropharyngeal stenosis, that could be accidental like in children, or it could be intentional, and 99% of the cases come with supraglottic stenosis or oropharyngeal stenosis. So this child actually has a oropharyngeal stenosis with the uvula you can see oropharyngeal stenosis. Just have to take a diode or a KTP laser and open this stenosis in a staged fashion. Don't try to open up in one go. Open it maybe after 1 week, do a dilatation and reopen it in 2-3 settings. You will be able to open up. And this child had come with a tracheostomy and Riles tube feeding. So this patient had come with the IV fluids and a tracheostomy. So a layered dissection. So organophosphorus poisoning, remember nothing happens to the subglottis or trachea, everything is in the supraglottis. Again similar, this is oropharyngeal stenosis, and as you go down the vocal cords and the lower respiratory tract is quite free of the pathology. Again it is intentional subglottic stenosis, but the entire area to be affected is the supraglottis, laryngopharynx and area-epileptic folds getting adherent to the epiglottis getting adherent to the area-epileptic folds. Just release them and you will open up the larynx. Okay. So what's the pathology again? This is the epiglottis and it has got adhered to the area-epileptic fold epiglottis. Just release the epiglottis and you will open up the entire larynx. So organophosphorus poisoning is another chunk of diseases which are going to come you with the supraglottic stenosis. This is a case of Wegener's granulomatosis. Again with a diode or a KTP laser you can remove bulk of the disease and have a patent airway. Post radiation very common these days. Try to see the affection of the cricopharynx, the supraglottis, the cricoarytenoid joints. You can just do a diode or a KTP laser which should be intramucosal. Okay, so just get rid of the edema if the patients come with edema with intramucosal passage of the laser, and when the patients come with fibrosis because of radiation you can again do dissection with the laser, dilatation in stage fashion and open up the supraglottic stenosis. Again chemical burns or chemical trauma in the supraglottis, and this is a cut commonly seen in I think Middle East countries, and this is the patient which has got a supraglottic stenosis. See this classical supraglottic stenosis here. You can see the epiglottis within the stenotic lesion. Okay. So, just this one clip I will try to explain. This is a supraglottic tumor in the interarytenoid area. The vocal cords are mobile. Now when you have to remove this lesion, whenever they are in the supraglottis, always remember the interarytenoid area, and this is the most difficult area to preserve the mucosa in between. I have told you in a case of laryngomalacia, in tomorrow bilateral abdominal palsy when you treat. So any surgery in the posterior glottis, you should be very observant about the mucosa in between the two arytenoids. Now remember, this lesion is between the is extending into the interarytenoid area. So removal of this disease has to be taken care of the mucosa in between the arytenoids, and this has to be explained to the relatives and patients well ahead, because when the patient has come, the vocal cord movement is quite good, the mobility is quite good, but when you are going to operate and remove this lesion, that could result in interarytenoid injury, and then vocal cords may not move after the surgery. Okay, so you will have to explain to the patient and take care to preserve the interarytenoid mucosa. So this is just to explain the interarytenoid mucosa preservation in case of supraglottic stenosis. So this is all the things. Again, I have injured the mucosa, but then I have taken the sutures to maintain the integrity of the mucosa. This is the post-surgery clip of the same patient. Okay. I think this is the clip of again an internal laryngocele. So another supraglottic pathology which is going to come to your clinic. Okay, I'm not sure. This clip is anyway. Is if it is played well and good, otherwise now you have to do a CT scan just to make it sure it's only internal and not external laryngocele. Now this again is a tube which is a metal endotracheal tube. When you are doing laser surgery, a laser resistant tube, the CO2 laser, you just have to open up. I'm just going to show you, tell you important things is laterally you should go up to the thyroid cartilage, check you have removed the capsule from laterally from the thyroid perichondrium, just to avoid any recurrence. So dissect the mucosal covering. Sorry, will finish this clip and I can't move forward. I think 2 or 3 minutes more. Fast आगे कैसे ले सकते?
Video next slide or video fast?
नहीं fast करने का है.
Maybe not this option.
I'm not able to. Okay, I'm not able to really fast forward it. So I'm separating the capsule from this mucosal cover. I'm not able to really fast forward it. This is the thyroid perichondrium. So internal laryngocele is another pathology. You have to just make it sure you keep in your mind while examining these children or the patients. The last is basically the laryngopharyngeal angiomas. Okay, they can be seen on your endoscopic examination. They are not going to come with history of bleeding disorders, but just a breathlessness, and this is the finding. You can do a KTP laser, a diode laser also can be done. Both lasers has to be used in a non-contact mode, and you can just get rid of these angiomas. Already seen this. You can use salivary dilators or balloon dilators in supraglottic lesions also. Basically, as I have told you, in organ of phosphorus passing, you have to just keep on dilating the lesions after the surgery. Don't try to do it one sitting. You can do balloon dilatations for the same patients as an OPD procedure also. what you have to do is pass the flexible laryngoscope through the nose and a balloon through the mouth. So you can always observe through the nasal endoscope and carry on the dilatation through the balloon which we have passed to the oral cavity. Okay, this is our studies, but most common is organophosphorus and corrosive agents, and next commonest is the radiation. Now this is only sentence I am going to. Supraglottic stenosis is notoriously recurrent, and why it is recurrent? Because it is involving the soft tissues. See, subglottis, you can get rid of that because it's a hard tissue. You can cut it and stitch it together. But soft tissues, they come back, try to come, they are known to be recurrent. Okay, like if you compare with the surgery of snoring surgery also is really not very well results because of recurrence. Because snoring is secondary to the soft tissue collapse. And same thing applies in the supraglottis, because if the soft tissue stenosis, it is quite recurrent and you have to take care as a stage procedures. Okay, laryngeal stents, very well as you said. I am just going to show you one slide why they have to be carefully monitored. Because laryngeal stents are known to give granulation tissue, and this granulation tissue at the lower end of stent is very troublesome. Okay, patients would come with a breathlessness, and you have to remove these granulations passing through the stent. So beware, don't keep these stents for more than 3 months and maximum 6 months. Above that, if you keep these stents, the patients would come with granulations again and again. And for these granulations, steroid nebulization and systemic steroids have been given by all the ENT surgeons and physicians. And remember, one patient, because of the recurrent steroids, recurrent nebulizations, and the stent was there for maybe more than 3 years, developed tuberculosis. So I think you have to take care, remove the stents in 3 to 6 months time. Fungal infection is very common if you keep the stent again for more than 3 to 6 months. Stent migrations can happen, and basically tracheoesophageal fistula could be also result of long-standing stents. I think this is the result. And supraglottic stenosis, again, now the newer generation robotics is also playing a good part in treating the supraglottic stenosis. Thank you very much for your patience.